Good morning, everyone. Thank you for the opportunity to give this talk today. This is the same talk that I gave last year. So these are my disclosures, which really have no impact on this talk, with the exception of the images that you see here. So if you Google the YouTube, my name on YouTube and this talk, this is the same talk that I gave last year, but the gentleman that you see here is not me, okay? So apparently there's another Isaac Akari here somewhere who looks similar to me. So I did receive a few phone calls from folks asking me why I look different. So that is the reason. So the true me is on the right side. All right, so just 1 second. I need to change my view so I can see my titles, but that's fine. Okay, so cervical sagittal plane deformity is quite disabling. In fact, if you look at EQ5D measures and compare that to chronic disease states, other chronic disease states, cervical kyphosis is just as disabling as patients with chronic emphysema, as well as patients that are blind. So a few studies are starting to come out. In fact, a lot of studies are starting to now focus on the impact of cervical kyphosis on patient-reported outcomes. One of the earliest studies was this early ISSG paper that looked at 113 patients who underwent multi-level posterior cervical fusion. And in this paper, they reported that patient outcomes were influenced greatly by their cervical alignment and not just the C7 plumb line. In fact, they were able to correlate that increasing C2 to C7 SVA correlated to worse outcomes when you looked at the neck disability index as well as the SF36. And after they did a logistic regression analysis, they established 4 centimeters as the threshold at which, if you exceed that, the patients had worse outcomes. So if you look at these two patients, the one on the left has a C2 to C7 SV of less than 4 centimeters. The one on the right has greater than 4 centimeters. And it's predicted that the patient on the right side who has an increased C2 to C7 SVA will have a worse outcome. At a pathophysiological level, increase in progressive cervical kyphosis does lead to increased spinal cord tension as well as lengthening of the spinal cord, which over time leads to some of the clinical manifestations that you see in myelopathic patients. This is a fantastic and very well done histological study that was done in Japan on 52 Japanese game fowls. And they were able to show that progressive kyphosis led to demyelination of nerve fibers, as you see here on the image on my right. The left one is the kyphotic game fowls, and the right one is a normal spinal cord. And you can see substantial demyelination of nerve fibers as well as neuronal loss in the game fowls that had progressive cervical kyphosis. And they also performed a microangiogram study that were able to demonstrate significant loss of intramedullary blood vessels as well. Now, despite everything that I've said so far, not all cervical kyphosis is normal. And this is really one of the key take-home messages of my talk. In fact, several studies have been done on normal patients, meaning that asymptomatic patients, and some of the studies have found as high as 26.3% of patients have normal cervical kyphotic spines, and some of those patients actually their kyphotic spines are not reducible. They are asymptomatic. And so when you are looking at a patient in clinic who you think may have cervical kyphosis, it is very important that you have to get a 3/4 film or EOS film to really look at the overall spinal alignment and not just the cervical alignment. So if you look at this picture to the right, just by looking at a limited view of the cervical spine, you may be fooled to think that this patient has cervical kyphosis. But if you look at the patient's overall alignment, this patient has a normal spine. So please keep in mind that cervical alignment has to be interpreted in the context of the overall sagittal plane. When you are seeing patients in clinic, you have to examine them in a standing position, in a seated position, and in a supine position. In the standing position, you want to examine their overall posture, their cervical musculature, especially some of these patients may have already undergone posterior cervical surgeries in the past and may have some of the muscle atrophy or anterior migration of the paraspinal musculature, which then will necessitate plastic surgery reconstruction of those muscles. Clinically, it is often my practice. Typically, patients with severe cervical deformity, I always do obtain clinical photos, and sometimes I ask patients to demonstrate which cervical posture is most comfortable for them, and I try my best to replicate that intra-op. Then while they're still standing, I have them walk to look for any evidence of myelopathy as demonstrated by any abnormal gait. I check the Romberg test to evaluate for any posterior core dysfunction. And then I also look at the overall how they're standing to see if that they are deploying any compensatory mechanisms to compensate for any hidden deformity. While they're sitting down, that this is a good time to do your classic neurological exam. The key thing here is to identify signs of cervical myelopathy. This is well known to all of you on this call, on this talk today. One of the things that I routinely do is to check a jaw jerk reflex, which if it's positive, it really is indicative of the hyperreflexia coming from the brainstem origin instead of a cervical spine. Now, lastly, you have to examine the patient, especially patients with semi-rigid or rigid kyphosis. These patients often will have a tough time relaxing their head. So they will have their head essentially will be suspended from the bed. Some patients who have rigid but not fixed cervical kyphosis, you ought to give them some time, even though it's uncomfortable, give them about 10 minutes, and slowly, once their neck muscle starts to relax, their head eventually will touch the pillow. So in terms of radiographic assessment, I always obtain full length as well. These days we have EOS here at Duke, so we have the luxury of able to see the patient's spine from head to toe. Dynamic x-rays are critical in the decision making here. And then a CT of the cervical with 3D reconstructions are very important so that you can evaluate which joints are ankylosed, which will determine which surgical approach that you may have to use to correct the patient's deformity. And then patients who have neurological symptoms will definitely need an MRI to look for any evidence of intraspinal pathologies. The CT angiogram is necessary if you're planning on doing some complex osteotomies. So there are a plethora of cervical radiographic parameters. The ones that I tend to use in my practice, which are fairly easy to use, are the CB, brow vertical angle, the C2 slope, the C2 to C7 lordosis, the C7 or T1 slope, the C2 to C7 SVA. And as I mentioned before, I always get full length x-rays on every patient presenting with cervical problem. Now, it is important to understand the concept of a T1 slope. The easiest way for me to understand it is just we all understand lumbar pelvic parameters very well. So the T1 slope is akin to pelvic incidence, such that just like a patient who has a high pelvic incidence will necessitate an exaggerated lumbar lordosis for them to stand upright. A patient who has a high T1 slope will need a larger cervical lordosis to be able to maintain a horizontal gaze. Recently, Temi and other members of ISSG have described the importance of the C2 slope. So the C2 slope, when using conjunction with a T1 slope, allows you to determine the location of the cervical deformity. I'll show you some examples of how you can use that. So for example, these images were borrowed from Chris Shaffrey. So let's say this is all the image that you had. You didn't have a 3-foot film. A patient who has a low C2 slope, which is less than 36 degrees, and a high T1 slope will have their deformity primarily hidden in the thoracolumbar spine. And so these patients will need a 3-foot films to really uncover the deformity that they're hiding in their thoracic or lumbar spine. A patient who has a high C2 slope and a low T1 slope have their deformity primarily in their cervical spine. So if you look at 3-foot films, the rest of their spine is normal. The deformity is in the cervical spine. And a patient with a high C2 slope and a high T1 slope will have deformities in both their cervical spine as well as your thoracolumbar spine. So that is how I use C2 slope and T1 slope to determine where the deformity may be hiding. So there are a lot of cervical radiographic parameters. The question is, well, which ones are the most relevant? That was elucidated by a study by folks from NYU and ISSG, where they did a retrospective study to determine which parameters were the most important. And in conclusion, what they found was that the C2 to C7 cervical SVA, C2 to C7 SVA, and the gaze parameters, which were your chin brow vertical angle, your side of light slope, and the McGregor's slope were, which are your gaze parameters, were the parameters that were the most important. And then every patient needs to be evaluated with all these parameters together and not in isolation. Another question, which is often very difficult, is just like we know in the lumbar spine, we can easily calculate, well, how much lordosis does this patient need to achieve spinal pelvic balance. The same can be predicted when you're doing the cervical deformity surgery using this equation that was elucidated by the same group that I presented the slide before. They did a retrospective review of 577 patients with normal horizontal gaze. And in this study, they took into consideration the patient's thoracic kyphosis, which were grouped into less than 30 degrees, between 30 and 40 degrees, and over 50 degrees, as well as the SVA. And they were able to come up with the cervical sagittal curve equation that you see here. But the most important take-home message from this study was that cervical kyphosis can be normal. Just because the patient has cervical kyphosis does not mean that the patient needs an operation on their cervical spine or needs the kyphosis to be corrected. And that horizontal gaze in this study was achieved with cervical Cobb angles between 8.7 degrees of kyphosis to negative 29.5 degrees. So very wide Cobb sagittal angles, even in patients that had normal cervical spines. So when you evaluate a patient with cervical kyphosis, the decision-making tree is pretty simple. Basically, you have to determine does the patient have a fixed deformity or a flexible deformity? If they have a flexible deformity, then you have an array of options that you can use dependent on what other symptoms that the patient may be presenting with. If they have evidence of myelopathy or radiculopathy, that may necessitate more or less an anterior type of surgery, or depending on what type of symptoms they're presenting with, they may require front back. So flexible deformities are essentially dealer's choice based on what the patients are presenting with. Now, when it gets more challenging is when they are presenting with fixed or rigid deformities. So patients presenting with fixed deformities that do not have ankylosed facet joints, if your spines are not ankylosed, then you can potentially restore proper alignment by doing an anterior release plus or minus a posterior fusion. Now, if their joints are ankylosed, let's say if they have a fused anterior uncovertebral joints or disc, then these are the patients that will require an anterior osteotomy with multiple interbody cages to really loosen up your spine before you can be able to restore proper sagittal alignment. Now, if they have a fused posterior lateral masses are all fused, these patients unfortunately will have to have the lateral mass fusion taken apart, followed by anterior, followed by posterior. So this is your classic 540 surgery. So I think Hanjo may have gone through this, so I won't go through it again. I'll just show you some patients examples. So this is a patient who is presented, for example, with flexible and mostly ventral compression on the MRI. I'm not showing the MRI, but that's what the patient had. So this patient can be successfully realigned with multi-level anterior fusion, as you see here. The image in the middle is the intraoperative position in X-ray, which demonstrate that the patient has rather flexible cervical spine. This is a patient who have a flexible deformity, but have both anterior as well as posterior compression. This is a patient that can be successfully realigned with the posterior only surgery, including a laminectomy. This patient has cervical myelopathy and has both anterior and posterior compression. So this patient was best treated with multiple anterior releases or anterior decompression and fusion, followed by posterior fusions. And this patient, classic chin and chest deformity, this patient will have fixed or rigid deformity. In this case, if you're lucky, if they're not ankylosed posteriorly, then they benefit tremendously from preoperative traction, which is what this patient underwent with Gardner-Wells tongues, followed by posterior and anterior fusion. This is a patient I treated about 6 years ago who presented with stable myelopathy. She had a history of cervical intraspinal ependymoma, underwent posterior laminectomy and removal of a tumor, and then developed a chronic fixed and ankylosed kyphosis. She presented with just difficulty swallowing and not being able to look upright, but her myelopathy was stable. So instead of having to do a true grade 7 osteotomy here, I took advantage of the ankylosed disc here in the front and essentially did an osteoclasis of the C5 and C6 with a corpectomy to be able to have her establish a horizontal gaze. And you can see these are her postoperative x-rays showing improvement in her overall cervical alignment. So this is what she looks like pre-op and post-op day 2 images. This is a patient of Krishnafri who have progressive myelopathy as well as a fixed and ankylosed spine. These patients, unfortunately, to be able to do a very good job to realign their spine will require a grade 7 osteotomy. So basically, posterior operation first to release the facet joints, as well as an anterior surgery to unroof the vertebral arteries before you can do a safe correction. So this is what that surgery looks like, and the patient did very well. So basically, that's my talk. Thank you very much.
Thank you, Isaac. It's a lot of information there, and it's great to have you and follow up with the Dr. Handro Kim lecture. 2 things I wanted to point out is, what's wrong with us in terms of myelopathy? Why do we not train and formally make the general medical population more aware of myelopathy? This is a national disease, and David's previous spinal cord injury identified how many elderly people are affected by that. So what are your thoughts in terms of making the message of myelopathy detection more prevalent amongst the medical students and the general medical population?
That's a good question. In my mind, I think it comes down to having the knowledge base and the proper training to be able to understand, number one, the pathophysiology of cervical myelopathy, and 2, how do you examine patients and also understand the natural history of it. And so I think that for as long as those things are emphasized in the medical training, I think that may help in the detection and treatment of it.
I agree, Isaac. This is Charlie Sansor. How are you doing?
Good. How are you doing, Charlie?
Good. I think another mechanism to increase awareness is to educate our radiologists. You know, very often you'll get a cervical MRI with severe kyphosis and there's no overt compression. However, there's an underlying stretch myelopathy that they have. And, you know, I think if we educate our radiology colleagues to be more cognizant of not necessarily looking just for stenosis, but also to be evaluating severity of kyphosis, you know, and you know how when the cord is basically strapped up against the posterior aspect of the vertebral bodies at multiple segments and there's no CSF in front of the cord, sometimes that's read as normal. And so I think, you know, having a radiology report that discusses the severity of the kyphosis and the absence of CSF in front of the cord.
That's a great point. Let me pick up on what Charlie just said. Isaac, question to you. What's the main pathomechanism that is so pernicious of cervical kyphosis? Is it a stretch problem? Is it a pressure problem? Is it perfusion? Is it malperfusion of CSF? What's the pathoetiology?
Yeah, I think that's a good question. I think most of the studies have shown that all of those factors that you mentioned does play a role. The question is what plays the dominant role. I'm not really sure, but I think it does involve, there's a vascular phenomenon that's as I showed on the Japanese game fowl study, and there's also a neuronal loss that occurs. So I think it's a combination of both parenchymal loss as well as a vascular process that contribute to the clinical manifestations that we see.
So let me share another great pet peeve frustration of mine here in Seattle, and I'd like to hear your thoughts how it is out east with you. PT for the neck. So you identified how important it is to have a head straight over your shoulders, over your pelvis. But I am very frustrated with our PTs when I send patients for neck rehab. I have patients who usually come back with more symptoms and are extremely unhappy and are more painful. And then when I look at what they actually did, it's rubbish. So do you have a similar experience out east? And do you have any thoughts in terms of us guiding a more meaningful rehabilitation of head-shoulder position?
Jess, can you ask that question again? You're breaking up.
What should we do to guide PT to do a better job with neck rehab than what they're doing? Out here, it's miserable.
Let me be honest with you. Sometimes, I'm not going to make this up. Sometimes we, including myself, rely substantially on the expertise of the physical therapist when it comes to specialized sort of treatments like that. So I essentially rely on them to use their expertise to help me out, and together we are able to come up with a plan. But I don't think I have a specific protocol that I provide to them to follow, to be honest with you. Do you?
Together with all the thought leaders here on this next generation, take control of this. I think it's necessary because what's going on out there is, at least here in the Northwest, nonsense. Very analogous to what Dr. Skaggs described about the Schroth method and the mystique of it. It's more mystique and mystery than real. So thank you, Isaac. We must move forward. So much to talk about. It's great to catch up next year, hopefully in person. Have a great day.
Sure. Thank you very much.